Okay, so good afternoon. After the vacation, the first topic for discussion is on multiple myeloma. So let's have some facts about the multiple myeloma. It's a clonal plasma cell disorder. So, plasma cells are involved when they become abnormal and when they are clonal, then they can cause one of the disorder called multiple myeloma. It constitutes 10% of hematological neoplasms. When you look at the total hematological neoplasms like leukemias, lymphomas, myelofibrosis, MDS, etc. It's generally common in the elderly age group. The median age in USA is 69 years. And why we quote USA is because most of the data is available from USA. So that's why we always look at epidemiological data from USA. So there the median age is 69 years. And this is the, their seed database. And you can see that most of the patients, almost 30% of patients are in the age group of 65 to 74 years of age. However, most of you who have seen patients of multiple myeloma in India, you must have seen that most of these patients belong to 45 to 55 years of age. So the median age of these patients, what you see in the ward or in the OPD is generally, younger. So maybe around 50 years, 55 years, 45 years, 40 years or so. It's more common in males. And myeloma is always preceded by a condition which is called Amgas or monoclonal gammopathy of undetermined significance. Now, little bit more introduction. Whenever you see M-band, now M-band is not equivalent to multiple myeloma. Presence of M-band can be a condition called monoclonal gammopathy of undetermined significance, as I said in my last slide. Or it can be a smoldering multiple myeloma. Both of these conditions all are called precursor conditions to multiple myeloma. However, M-band can be present in various other conditions. And the two other uncommon conditions are amyloidosis and Poems syndrome. And obviously in myeloma, M-band can be present in multiple myeloma in almost 80-85% of patients. Now, previously, the concept was that patient can present with Amgas, patient can come in smoldering multiple myeloma, patient can have multiple myeloma. But in USA, when they check the blood sample of those patients who have been diagnosed with myeloma today, they had blood samples which were stored for some other condition, 10 years back or 15 years back. So then they saw that patients who have developed myeloma now, they had a presence of M-band even 10 years ago, meaning thereby that all myeloma patients actually evolve from a condition called Amgas or smoldering myeloma. So from Amgas directly multiple myeloma or Amgas smoldering myeloma and multiple myeloma. Now, after this little brief introduction, let's understand all these things in more detail. And we discuss about a case of a patient who is a 65 years old gentleman and was being evaluated in the medical OPD for exertional breathlessness. The examination was normal except the blood pressure was on the higher side, 160 by 100 millimeter of mercury. And a few investigations were done, and obviously somebody at this age who has exertional breathlessness, some hypertension, you would do the ECG. The ECG showed T inversion in the inferior leads. So obviously, if there is T inversion in inferior leads, that means there is a myocardial ischemia which is going on, and you will refer the patient to cardiology. The other investigations which were as a routine were done was hemoglobin was 13, normal white cell and platelet counts. The LFT proteins 8 grams and albumin 3.5 and 4.5. and OTPT alkaline phosphatase 20, 18, and 106. RFT was normal. So obviously sitting in the medical OPD, you will send the patient to cardiology for an angiography. So coronary angiography was done, which showed 80% block in the left anterior descending artery. So the angioplasty and stent placement was done. The blood pressure was controlled. The patient felt better and he's back to his normal routine activity. There is no breathlessness and the blood pressure is now less than 130 by 80 millimeter mercury on beta blockers, statins and aspirin. Now everything is okay. The patient has come with a complaint and patient is better. But do you think, is there any abnormality in any parameter? If you, I don't know how many of you can, I don't know whether it's a two-way communication or not, but if it is a two-way communication, so you can, we can discuss something or you can put a chart in box. Yes, somebody mentioned total increased proteins. Yes, so the patient was smart. So he said, doctors, are my proteins elevated? Now in the cardiology, the doctor said, I don't know, maybe lab abnormality, you are okay, otherwise okay, but yes, we can refer back to you to the medicine department. So now the patient has come back to you and he says, I am otherwise all right, my blood pressure is okay, my breathlessness is better, but so, are my proteins elevated or would you, as a medicine resident, do anything? So always remember one thing, whenever you see the total proteins or serum globulins or when there is a reversal of albumin globulin ratio, always send the sample for protein electrophoresis and serum immunoglobulin levels. And you would see this condition of abnormal proteins, reversal of AG ratio, in many conditions, including autoimmune conditions, liver disorders. But, to know what is the status of these proteins, so you do a serum protein electrophoresis. So the serum protein electrophoresis in this patient showed M band. Now, what would you do next? So patient with an M band, as I said previously, you have to find out whether this patient has a condition which is called Amgas, or a patient has a condition which is called smoldering multiple myeloma, or a patient has a condition which is called multiple myeloma. And we will discuss these mainly these three conditions in the subsequent slides. Why we need to differentiate? Because Amgas does not require treatment, only follow-up. Similarly, smoldering also does not require any treatment, and there is a future risk of going into multiple myeloma. And if it is a myeloma, it requires an immediate treatment to prevent complications. The other two conditions like amyloid and POEM syndrome, which are two other conditions where there can be an M band, they also require treatment immediately. But our patient is asymptomatic. So what would you do? So you will look at the investigations. You saw that the hemoglobin was almost normal. Creatinine was okay. Serum calcium was 9. So what we are looking at, CRAB criteria, CRA, no hypercalcemia, no renal failure, no anemia. But we are also looking at the bone evaluation, which is done either by a skeletal survey in the past and in the past, it was the skeletal survey, and these days we do an ultra low dose whole body CT scan or a PET CT scan, and a PET CT scan was done. I think my slides are not moving. Abhishek has, I don't know why my slides are not moving. Okay, now they are moving. Okay. So skeletal survey or PET CT scan, no FDG avid lytic areas. So what would you do next? So you would obviously do a bone marrow examination, which showed 6% of plasma cells. So obviously you would look at these plasma cells, whether these are clonal or not. And for that, you do a flow cytometry, which shows these were clonal plasma cells, CD38 positive. You would also do an M-band quantification, which came out to be 1.5 gram per deciliter. And now further, you would actually want to see this M-band, what is the heavy chain and the light chain which is involved. For that, you do an immunofixation, which showed it is the heavy chain is IgG and the light chain is kappa. And a test you must have ordered many times, serum free light chain assay, which showed kappa was elevated, lambda was normal, and the ratio was 4. So is it multiple myeloma? Obviously not. It is a condition which is called Amgas. And now let's define Amgas. Amgas is defined when the M-band quantification is less than 3 grams per deciliter. The bone marrow shows less than 10% of plasma cells, and there are no CRAB features, no hypercalcemia, no renal failure, no anemia, and no bone lesions. Even if there is hypercalcemia, you have to attribute this hypercalcemia to the plasma cells. So sometimes, these patients may have hyperparathyroidism and they can have hypercalcemia. Or these patients may have diabetes and the renal failure may be due to diabetic nephropathy. So you would make a diagnosis of myeloma only if the renal failure is because of myeloma and not because of anything else. And sometimes it becomes difficult in a patient who has diabetic nephropathy, whether this nephropathy or the renal failure is because of myeloma or because of diabetes. But you would diagnose Amgas by these parameters. So what is the importance of Amgas? In USA, near the Rochester, there was a village with the population which was 60,000-70,000. They did these protein and serum protein electrophoresis, all those patients, and followed up those patients almost for 30 years. And the patients who have M-band, they also were followed up for almost the same duration. And this paper was published in 2002 in New England Journal of Medicine. So basically, they looked at what is the what happens to these patients who have M-band but does not have myeloma. So what they found was that the risk of progression of Amgas to multiple myeloma or related disorder is about 1% per year. That if there are 100 patients with an M-band and who have Amgas, one will progress to either myeloma or to related disorders. And related disorders are obviously Waldenstrom, primary amyloidosis, plasmacytoma, sometimes lymphoma, CLL. You can also see these M-band. Now, obviously, the next question patient is asking the doctor, okay, I have Amgas, that means nothing is to be done right now, but what are my chances of progression? Can you predict whether I come in those 1% where I'm going to progress, or I'm in 99% where I'm not likely to progress? So obviously, what we do in the clinic is do a risk stratification. Risk stratification means we would like to see whether this patient has what are his chances of progression. So for that, we have actually at least 5 parameters or 4 parameters in the clinical setting. One is the looking at the concentration of M-band, the type of M protein, serum free light chain ratio, number of plasma cells in the bone marrow, and reduction in polyclonal immunoglobulin levels. Now, if the M protein is high, that means if it is, if it is 0.5, the 10-year risk is 6%. If it is 1 gram, then it is 7%. And as the M-band quantity goes up, the chance of progression goes up. For example, at an M protein of 3 gram per deciliter, the chances of progression is almost in 1/3 of patients. So that means it is very important to know what is the concentration of M protein whenever you diagnose the patients having an M-band in a patient with Amgas. Then you look at the type of M protein. Type of M protein means what is the heavy chain which is involved. And for that, this is one of the paper looking at this, where they showed that if it is IgA heavy chain, it has higher progression then IgM or IgG. IgM generally happens in Waldenstrom macroglobulinemia, but sometimes rarely in myeloma also. So IgA, if it is IgA Amgas, then it has higher chances of progression than IgG. Then you look at the serum free light chain ratio. The serum free light chain ratio, whether it is normal or abnormal. So people have looked at this as an independent risk factor for progression. And in this paper, which was published in 2005, they saw that the risk of progression in patients with an abnormal free light chain ratio was significantly higher as compared to patients with normal. The fourth is the number of plasma cells in bone marrow. Even though we have said the plasma cells percentage in Amgas is less than 10%, but even in 10%, if the plasma cells are between 6 to 10% or 6 to 9%, then the chances of progression are high. In this paper, they have looked at the same 0 to 5% plasma cells, and these are, we are talking of clonal plasma cells, which you can see either by immunohistochemistry or by flow cytometry. So somebody who has 6 to 9%, the progression is 46%. So that means it is important to do a bone marrow examination in these patients to know the progression. So in a multivariate analysis, if you combine all these factors like abnormal free light chain ratio, M protein size, as well as IgA, so you add all these factors, the risk of progression obviously would be higher. So this risk actually, depending upon one factor, abnormality, two factors, or three factors, you can see the risk, relative risk goes up from 1 to 5.4 to 10.1 if all the three risk factors are, if the three risks are abnormal, then it is almost 20.8%. So what is in our patient? In our patient, the serum immunofixation was IgG kappa, light chain was abnormal. So obviously our patient who has an M band of 1.5 gram, IgG kappa, 6% clonal plasma cells, free light chain was abnormal. So the risk of progression is little higher than 1% per year. So the course of this patient, you would not do anything right now, Amgas. You just need to monitor this patient, and you would tell the patient, please do CBC, RFT, calcium, and electrophoresis, every 6 monthly, and follow up the patient and follow up. So after 2 years on follow up, the hemoglobin from 13 has dropped to 12. The calcium was still normal, but it was little on the higher side, 10, and the M band was 3. So obviously in this patient there is some progression from M band has doubled 1.5 to 3, and there is a mild drop in hemoglobin. So now the patient is asking me, doctor, I am suffering from myeloma, and obviously you would say that we need to investigate further whether you fulfill the criteria of myeloma or not. So you do a repeat bone marrow. So this is a little bit hypothetical patient just for the understanding. So obviously the Amgas patients do not progress so fast. So in this patient, when a bone marrow was done, it showed 50% plasma cells, which on IHC was kappa restricted. So is it multiple myeloma? So now we define these three conditions like Amgas, smoldering myeloma, and multiple myeloma. So Amgas we have defined previously, M band protein less than 3 gram, bone marrow plasma cell less than 10%, and no CRAB features. That means no organ dysfunction in the form of hypercalcemia, renal failure, anemia, or bone lesions. Now the other precursor condition is smoldering multiple myeloma, where the M protein is actually more than equal to 3 grams. The bone marrow clonal plasma cells are more than 10%, but less than 60%. But still there are no CRAB features, and there are absence of myeloma defining events, including biomarkers of malignancy or amyloidosis. And we will discuss about some biomarkers. What are these biomarkers? And myeloma you define when the M protein is more than 3 gram or bone marrow clonal plasma cells more than 10%. So this is, what is overlapping with smoldering myeloma also, but you have CRAB features. So any patient who has CRAB features or biomarkers, and these biomarkers are involved, uninvolved serum free light chain ratio of more than 100, more than one focal lesion on MRI, which is at least 5 millimeter in size. So previously, these definitions were not there. Only CRAB was there. So even somebody who has a plasma cells of 90% but no CRAB features was classified as smoldering myeloma. But after 2014, this criteria is changed, and even somebody who does not have CRAB features, that means no organ dysfunction, but has serum free light chain ratio which is more than 100 or one focal lesion on MRI, that or more than 60% plasma cells, that patient still is called multiple myeloma. So the patient is asking whether I'm having myeloma or not. So the doctor is saying, no, possibly you have a precursor condition called smoldering myeloma, but we need to investigate further. Now here also in smoldering myeloma, like in Amgas, we did the risk stratification. So here also we are doing the risk stratification of smoldering myeloma, whether they are falling into low risk or high risk or intermediate risk. And this is based on the number of bone marrow plasma cells, which may be more than 20%, M protein, which is more than 2 gram, and free light chain ratio more than 20, but less than 100. So this rule is called 20 to 20, 20 to 20. So based on this, if you can estimate the risk of progression at 2 years, 5 years, and 10 years. Somebody who has a bone marrow plasma cells more than 20%, like in our patient, M protein more than 2 in our patient, and the free light chain ratio more than 20, which we yet to see, then the risk of progression actually at 2 years is almost 50%. That means that if you have 10 patients, 5 patients are likely to progress. So you have to be very, very careful in these patients because they are likely to progress. Whereas if the patient has a low risk, his chances at 10 years are 50%. So this is akin to what you have seen in chronic lymphocytic leukemia. Also, many of you who have read chronic lymphocytic leukemia or read about chronic lymphocytic leukemia, you have RAI A, RAI B, even though you have a chronic lymphocytic leukemia, but you don't give any treatment to those patients. So similarly, Amgas and smoldering myeloma are kind of a stage A, RAIS stage A, RAIS stage B, kind of, or RAIS stage 1 or RAIS stage 2 kind of a myeloma where you do not require any treatment. So in this patient, when the patient is asking, whether I have myeloma or not, they say we do a free light chain again and MRI spine and pelvis. So in our patient, when the serum free light chain was done, so kappa had gone up to 230 and lambda has gone down to 2. And this ratio is now more than 100, whereas MRI whole spine and pelvis was normal. So this patient actually would fit into a diagnosis of multiple myeloma with myeloma defining criteria like C is hypercalcemia, renal failure, anemia, bone lesions, nothing is there. S is 60% plasma cells, which this patient has 50%. Li is light chain abnormality, more than a ratio more than 100, which this patient has. And M is MRI, no lytic areas. So this patient would fulfill the definition of myeloma by myeloma defining events. So in 2014, International Myeloma Working Group, which we call as IMWG. IMWG is the International Myeloma, who gives the criteria for diagnosis and assessment, risk assessment, as well as response assessment, as well as give treatment recommendations. So they updated the criteria for diagnosis of multiple myeloma, which previously, as I said, was based only on CRAB, but now we have myeloma biomarkers of myeloma, and based on that also you can make a diagnosis of multiple myeloma. So the definition is currently is that the clonal plasma cells more than 10% in the bone marrow, or biopsy proven bony or extramedullary plasmacytoma, and any one or more of the following myeloma defining events like hypercalcemia, renal failure, anemia, and bone lesions, either on skeletal radiography, ultra low dose full body CT scan or a PET CT or an MRI, and any one of the following, like clonal plasma cells percentage more than equal to 60%, involved uninvolved serum free light chain ratio of more than equal to 100, and more than one focal lesions on MRI studies. So you can make a diagnosis of myeloma based on these parameters, provided they have either biopsy proven bony or extramedullary plasmacytoma or clonal plasma cells more than 10%. Whereas the definition of smoldering myeloma is when the monoclonal protein is more than 3 gram or urinary monoclonal protein more than 500 milligram, and the clonal plasma cells varies from 10 to 60%, and there is absence of myeloma defining events or amyloidosis. So if there are myeloma defining events, irrespective of plasma cells, you will make a diagnosis of myeloma. So let's say even if the plasma cells are less than 10%, which happens rarely, but if you can say that the renal failure is because of plasma cells or the bone lesions are because of plasma cells, even then you will make a diagnosis of multiple myeloma for the treatment purpose, even though it will not fulfill the book definition of multiple myeloma because the plasma cells are less than 10%, but that is a rare situation. The other plasma cell dyscrasias sometimes are non-IgM monoclonal gammopathy, light chain monoclonal gammopathy of undetermined significance, solitary plasmacytomas, solitary plasmacytoma with minimal bone marrow involvement. I am not discussing this, I don't think so. This is actually required at MD level, but somebody who is interested in hematology can go through this paper and read these definitions. So further follow up, when you are making a diagnosis of myeloma, you would make further tests like beta-2 microglobulin, serum LDH, bone marrow with FISH cytogenetics, looking at the albumin, immunoglobulin levels, 24-hour urine protein, and urine protein electrophoresis if there are proteins which are more than 200 mg. Why we need to do that? Because we need to stage these patients, and currently we stage these patients by revised international staging system, what is called as RISS. It has three staging systems: stage 1, 2, 3. Stage 1 is when the albumin, serum albumin is more than 3.5, beta-2 is less than 3.5, no high risk cytogenetics, and we will discuss in subsequent slide what is high risk cytogenetics, and normal serum LDH levels. Whereas stage 3 is when the beta-2 is more than 5.5 and there is high risk cytogenetics like 414, 1416 or deletion 17p or elevated LDH levels. That's why it's very important to do beta-2 microglobulin LDH level in all patients who are suspected to have myeloma. But many of these patients do not fulfill the definition of stage 1 or stage 3, and these patients come into the stage 2. So sometimes, the LDH is normal, or the beta-2 is high, or beta-2 is normal, but the LDH is high. So all these patients will come into stage 2. And these are the cytogenetics which can be present in myeloma. Either there can be trisomies or 1114, 414, 1416, 1420 and other IGH translocations. So almost trisomies are present in almost half of the patients, whereas IGH translocation are present in 30% of patients. So after you have made a diagnosis of multiple myeloma, we will discuss a little bit on treatment, another 7-8 minutes. We have plenty of medicine now. And these medicines, these drugs, you can divide these into chemotherapy like melphalan, cyclophosphamide, bendamustine, doxorubicin, cisplatin, vincristine. You have corticosteroids, dexamethasone and prednisolone. You have immunomodulatory drugs called IMiDs, thalidomide, lenalidomide, pomalidomide. You have proteasome inhibitors like bortezomib, carfilzomib, ixazomib. You can do an autologous or allogeneic hematopoietic cell transplant in these patients. We have antibodies now like daratumumab, elotuzumab, isatuximab. We have HDAC inhibitors like penobinostat. We have targeted therapy like venetoclax, which is BCL2 inhibitor. We have bispecifics antibodies which are coming up, and we have CAR T cell therapy. So the number of therapies in the last decade or so have gone tremendously in the treatment of multiple myeloma. So about the treatment of multiple myeloma, we must understand that it is a heterogeneous disease because we are staging these patients and we have seen lot of cytogenetic abnormalities. It is still an incurable illness. The median survival varies from 7 to 10 years in most patients, and treatment can prolong life. Infections are the most common cause of death in these patients. So what are the goals of therapy for myeloma? So you reverse the ongoing or impending organ dysfunction. As I said previously, that you will make the diagnosis of myeloma when there is a ongoing organ dysfunction in the form of Kreb criteria or biomarkers of malignancy. You want to improve the progression-free survival and overall survival of these patients. You also want to maintain safe and maintain the quality of life of these patients. And obviously, whatever drugs which you are giving, you want a cost effectiveness of all these therapies. So how do you reverse the ongoing or impending organ dysfunction, which I said renal failure, spinal cord compression, or hypercalcemia? The fastest acting anti-myeloma drugs are steroids like dexamethasone and proteasome inhibitors called bortezomib. So the goals of therapy of prolonging life, how can you prolong life? By improving the progression-free survival of these patients. So whenever you give any therapy to these patients and these patients have any kind of a response, that will prolong the life of this patient. The long-term survival is only achieved if these patients achieve complete remission and minimal residual disease negative status, and we will discuss a little bit about these response criteria. So the response criteria in multiple myeloma are given by International Myeloma Working Group, IMWG. So when there is more than 50% reduction of serum M protein or reduction in urine M protein more than 90%, then it is called partial response. Then very good partial response, that M band is detected by immunofixation, but negative on serum protein electrophoresis. So many times you will see serum protein electrophoresis, there is no M band. And you do immunofixation, it comes as immunofixation is positive. So this response is called VGPR, or if the urine M protein is less than 100 milligram per 24 hours. Then a response which is called complete remission, which means negative immunofixation on the serum and urine, disappearance of any soft tissue plasma cells, and you do a bone marrow examination which shows less than 5% plasma cells. So at the time of diagnosis, you are making diagnosis only when the plasma cells are more than 10%, but here at the time of complete remission, they should be less than 5% plasma cells in the bone marrow. Then there is a response criteria which is called stringent complete remission, which means that you have a normal free light chain ratio and CR. So this is called stringent CR. Then a status which is called MRD, negative status. You do either by flow cytometry or by next generation sequencing, whatever method you use. So if MRD is negative, then this is the deepest response. So these CR, stringent CR, MRD is called deepest remission. Somebody who is in this state, he will have a prolonged life as compared to patients who are in PR or VGPR. So hence the treatment aim is to achieve deeper remission. So, and the best way to achieve deeper remission is to give high dose chemotherapy followed by bone marrow rescue, what we call as autologous hematopoietic cell transplant. So in myeloma, previously the concept was preserve the drug because the myeloma is remitting relapsing illness, and we had very few drugs, so we wanted to preserve the drugs. But the current concept which is coming up in myeloma is that you aim for continuous remissions as the drugs are plenty. So if the drugs are safe, we have targeted drugs, they do not have much side effects, you can continue the treatment so that these patients do not relapse. So the other goals of therapy obviously are when you are doing this, so you want to improve the PFS and OS, and quality of life which you want to maintain. So once the diagnosis is made based on CRAB or MDE criteria, the first decision also is whether this patient is autologous transplant eligible or ineligible. And this eligibility basically is based on somebody who is young, less than 65, but even somebody at 70 years but otherwise fit can be eligible, who's healthy and fit to withstand complications of high dose melphalan. So the other variables which decide about the anti-myeloma drug combination at the time of treatment is, as I said, transplant eligibility, comorbidity. Somebody who is diabetic, hypertensive, neuropathy, renal failure, you would obviously try to see that you do not further compromise the quality of life. Look at the cytogenetics, renal failure, ISS stage, extramedullary disease, plasma cell leukemia, and of course, in India, we look at the finances and the socioeconomic status of the patients. As said previously, the myeloma is a heterogeneous disease, and generally we divide these patients into standard risk, intermediate risk, and high risk based on various parameters. And the standard risk, generally the median survival is more than 10 years. Intermediate is the median survival is 10 years, and the high risk is generally 2 to 3 years. So that can, you can prognosticate the patient. But this, will work only if you choose and give appropriate regimen to these patients. So the induction therapy for transplant eligible patients, as I said previously, we have plenty of medicines. How do you choose? And one of the good thing in myeloma is that you can combine all these drugs with each other. So, so one question is that you combine all of them, but obviously the number of side effects goes up. So generally what you do is you give a combination of triplet. Triplet means you give combination of 3 drugs. So previously when people were giving 2 drugs like melphalan, prednisolone or VAD, Thal-Dexa, so these were the CR rates, complete remission rates, which we defined as negative immunofixation and bone marrow less than 5% plasma cells. So these were the complete remission rate. But when they combined the third drug like thalidomide, lenalidomide or bortezomib based regimens, so you can see these response rates actually are going up very high. And when you combine with an autologous transplant, these complete remission rates are crossing more than 40% or so. So meaning thereby that these patients, if you try to give 3 drug combination and somebody who is transplant eligible, if he undergoes an auto transplant, his chance of being in complete remission are very, very high. So for the last 10 years or so, we are now using 3 drug combination. As I said previously, one is dexamethasone, the other is proteasome inhibitor, and the third is an immunomodulated drug like bortezomib, which is Velcade, R is Revlimid or lenalidomide, and D is dexamethasone, or V bortezomib, T is thalidomide and dexamethasone, or dexamethasone, proteasome inhibitor like bortezomib, and alkylator like Induction. This is called VCD. So these are the terms which are used: VRD, VTD, VCD. D is dexamethasone, V is bortezomib. So almost you can see that most of these patients will receive dexamethasone and bortezomib, and the third drug is either thalidomide, lenalidomide, or cyclophosphamide. The overall response rates with these combination is almost reaching up to 90%. VRD regimen costs 10,000 rupees a month. Sometimes we do compare RVD and VCD. It is little bit intensive regimen, sometimes tolerability issues, and lenalidomide is excreted through kidney. So many times you want to avoid that drug. And these lenalidomide is also toxic to the stem cell. So you need to do the stem cell collection after 4 to 6 cycles. The cost is approximately 9 to 10,000 per month. VCD is less intensive, easy tolerability. Most of the patients who have renal failure, we tend to give cyclophosphamide to these patients. And once their renal failure recovers, then we shift to RVD. But you can continue with VCD regimen also. The stem cell collection can be done, and the cost is 5,000 per month. So upfront regimen which are used, as I said, VRD, VCD, and VTD. The duration generally for a transplant eligible patient is 4 to 6 cycles, followed by transplant. These days we have an antibody which is anti-CD38 antibody called daratumumab, but it is quite expensive. It can be added to any of these regimen, but the cost is approximately 32 lakhs for a 6 months. So, you know, you must have seen some patients are getting this drug, either who have reimbursement or who are affordable. But out of, let's say, 20, 25 patients of myeloma, probably only one patient can afford daratumumab. And this is one of the trial showing dara, len, boti, and dexamethasone combination. This is called Griffin Trial, and you can see if you add daratumumab, the progression-free survival from 90% goes up to 96%. But the good thing is, even if you are giving RVD, almost 90% of patients are achieving a good PFS as 2 years. For some of the patients in our setup who are financially poor, cannot afford, so you can use the other regimen also. And the Asia Myeloma Network, we gave some of these recommendations for combination of these medicine like cyclophosphamide, thal, dexa, which will cost something like 1,500 rupees or 2,000 rupees per month. So very cheap. So some of these regimen you can use for if the finances are limited. And MPT, Theldexa, even 2-drug combination can be used. Theoretical purpose, obviously, if somebody can afford, you would like to use 3 drugs. But sometimes, if there are financial difficulties, you can use 2 drugs also. As we have shown in the previous slides, that any response in myeloma will lead to prolongation of survival of these patients. We also have Indian Myeloma Academic Group, for which we have given some consensus guidelines in 2016 conference, which was done at PGI. So patients who are eligible for transplant are those who achieve more than VGPR. And this is our experience of myeloma, which was published, I think, 2018 or so. We have almost 77% of patients who are are going beyond almost 6.5 years or so. So if you do an auto transplant for these patients, a good number of patients are having good PFS. After transplant, generally these patients are put on maintenance therapy, which is called lenalidomide. For transplant ineligible patient, obviously you need to do a geriatric assessment, and the current therapy for myeloma for these patients is you continue the treatment until disease progression, because if you stop the therapy, myeloma is likely to come back. So lenalidomide and dexamethasone you can give. You can also give daratumumab based regimen with boti, melphalan, prednisolone. This is one of the trial which is called Alcyon. And you can see that if you add daratumumab to these patients have a better PFS at 24 months. So future of myeloma therapy is, it's going to be like an acute leukemia-like therapy. You have induction, consolidation, and maintenance. So induction therapy you do with 3-drug combination, whatever drugs which you have, RVD plus daratumumab or carfilzomib, lenalidomide, dexamethasone with daratumumab. You consolidate with an auto transplant or some consolidative therapy, which is almost the same which you have given in induction therapy. And then once you achieve an MRD negative status or a stringent complete remission after 9 to 12 months of therapy, you put this patient on maintenance therapy indefinitely. So these induction, consolidation, maintenance is generally term used for acute leukemia therapy, and this is also coming up in myeloma therapy. Now, why it is important to use effective upfront therapy? Because in the early disease, there is less genomic instability and CR is easy to achieve in upfront therapy. Whereas in the relapsed disease, you have more genomic instability and the patients may not respond to treatment. So coming to the algorithm, which is given in one of the article by Shachi and Vincent, standard risk, which is 11, 14, 6, 14, and trisomies, VRD, as I said, or approximately, these are transplant ineligible. So give for 12 months, then followed by only then maintenance. For intermediate to high risk, you give for 3 to 4 cycles, followed by, sorry, this is transplant ineligible. So you continue for 12 months, followed by maintenance either with bortezomib or combination of bortezomib and lenalidomide. For transplant eligible patients, you give 4 cycles, followed by stem cells. So you do an early transplant for most of these patients, followed by len maintenance. This is changed now. So here it is written maintenance for 2 years, but now you give indefinitely. So again, indefinitely bortezomib, or in high risk, both combination of bortezomib and lenalidomide. Finally, coming to conclusion, we have come a long way in the treatment of myeloma. In 2000, the survival was 2 to 3 years for all these patients. But now most of these patients are surviving beyond 7 to 8 years. So as I said, median survival from less than a year now is more than 10 years. The induction therapy is now PI, proteasome inhibitor with IMiDs and corticosteroids. Transplant eligible patients undergo auto transplant after 4 to 6 cycles. Patients achieving MRD negative status at day 100 post-transplant have long-term, very good long-term survival. And these patients get either lenalidomide or bortezomib-based maintenance therapy indefinitely. And transplant ineligible patients get continuous therapy for at least 12 months, followed by maintenance therapy. I think with that, I end my presentation. And if there are any questions, I would be happy to answer those questions. So any questions? So question by Pranjal, is there a reason for doing an auto transplant in myeloma instead of allogenic transplant? Yes, so the concept of auto and allogenic transplant is totally different. Autologous transplant is like a consolidation therapy. Like you are not curing the illness, you are only consolidating what you have achieved with the induction therapy. So sometimes the disease is not curable. So allogenic transplant is done where you are want to use when you are changing the immune system and somebody else immune system is curing the illness. That what is we call as graft versus leukemia effect or graft versus myeloma effect. So even though there is graft versus myeloma effect in myeloma patients by doing an allogenic transplant, the problem is for allogenic transplant when you are doing these patients have very high mortality. So almost 40% or so, which is generally we say the transplant mortality should be less than 10%. So 40% is not, is not expected. So that's why you don't do allogenic. The second is even though there is graft versus myeloma effect, but it is not as effective as in other disorders. That means you are taking a lot of risk also for doing an allogenic transplant. But even then, the graft versus myeloma effect is not very good. You don't want to take that risk. And as I said, these days now we are having CAR T cells and bispecifics and a lot of other therapies which are coming up. So role of allogenic transplant is going down in these patients. And in the first slide, I showed that the median age is very 65 years or above. So obviously these patients are allogenic transplant ineligible. So many reasons. It can take a full lecture on that. So so that is briefly why an allogenic is not preferred. So the next question by Dr. Nicholas, sir, when can we bring CART in the management of regimen? So CART is obviously very upcoming regimens in lymphomas, leukemias, and even in myelomas also. So right now the CART are kind of getting approval for relapsed refractory myeloma patients. One of the reason is that once you do CAR therapy, then you have changed the stem cells of the patient. So we don't know the other therapies, how much they will be effective. And right now, we don't have phase 3 data where they have shown CAR T is better than the other available drugs. So right now, CAR is coming up very fast, but right now in myeloma, it is reserved for relapsed refractory patients and not upfront. But in future, if you ask me, for after 4 or 5 years, it is possible that we do away with an auto transplant and bring CAR at that time. Okay, the next question by Sarthak, sir, any role of carfilzomib over bortezomib? So even though both are proteasome inhibitors, and when the carfilzomib came for the first time, it was said that possibly it is more effective than bortezomib. But the trials which are done upfront, comparing bortezomib with carfilzomib, they have not found any significant difference in response rates. So in the upfront setting in newly diagnosed patients, there is not much of a difference if you are using carfilzomib or bortezomib. In a standard risk patient, so this trial was done in standard risk patients. In high risk patients, we don't know. Possibly in high risk patient, there might be little advantage of carfilzomib over bortezomib. But it is only one trial which is showing some advantage, but in the standard risk there is no advantage. Whereas in the relapse setting, if you have not used bortezomib upfront, then if somebody says out of these two drugs, then carfilzomib may be little better in the relapse setting. The next question by Madhav is, what amount of M protein should alarm us to further investigation for Amgas or smoldering myeloma? So any amount of M protein, if it is there, it is obviously monoclonal component. M is monoclonal. So you need to find out whether you have Amgas, myeloma, or smoldering myeloma, or as I said, amyloidosis, Poem syndrome, or some other lymphoproliferative disorder. So obviously, you need to systematically examine the patients, see, why did you do the M band, whether it was a routine test which you did because of the altered albumin globulin ratio, or the patient has presented with some symptoms. If the patient is symptomatic, then obviously you need to find out whether these are related to M band or not. For example, in the cardiology posting, somebody has come with unexplained heart failure and you do an M band, then possibly this patient is likely to have amyloidosis. Similarly, in the hepatology, you see the altered ratio, the patient has large liver, which is you are not able to explain, and there is an M band, likely to be an amyloidosis of the liver. Whereas in the other medicine wards, in the patients who have unexplained renal failure, if you have an M band, it's likely to be related to a condition which is called MGRS, monoclonal gammopathy of renal significance, which I have not discussed. So I think it all depends when you look at the M band, whether it is detected routinely or the patient has come with some problem, and then you have to correlate the things, whether this M band has any significance for the current problem of the patient or not, and based on that you need to do the further testing. But even if the patient is asymptomatic, I would suggest that at least look for CRAB criteria by doing a serum calcium, looking at the hemoglobin, looking at the bone lesions and the bone marrow examination. The next question is by Dr. Deepak. What is the role of venetoclax in the management? So venetoclax is a targeted medicine, which, as I said, it is a BCL2 inhibitor. So patients who have cytogenetics 1114, and these are those patients of myeloma or patients who have amyloidosis also actually. So there, a trial which was done by the name Bellini trial, they showed that venetoclax is very effective against this particular patients who have 11-14 or high BCL expression in the bone marrow. So, but venetoclax is otherwise quite toxic. So the role is still getting evolved uh, in myeloma as compared to the role of venetoclax in CLL and in AML. But it is a targeted, one of the targeted medicine targeted against 11-14 in multiple myeloma. Any specific difference between AL amyloidosis and multiple myeloma? Yes, you have to see whether it is so whenever diagnose with myeloma, you also have to see whether the patient has amyloidosis, concomitant amyloidosis or not, or whenever you diagnose amyloidosis, you have to see whether the patient has multiple myeloma or not. So there can be three situations. One is pure multiple myeloma, one is pure amyloidosis, and the third is both myeloma and amyloidosis together. So the good thing is most of the therapy which are used for myeloma are also used for amyloidosis also. So so even though amyloidosis, you would like to see whether the patient has cardiac involvement, liver involvement, renal involvement, and some of the organ dysfunction which is going on, you will monitor that. So that is what you have to see when you see a patient of myeloma or patient of amyloid. So you have to differentiate whether the patient has pure myeloma, pure amyloid, or overlap. If it is an overlap of myeloma and amyloidosis, you generally treat by give the same treatment as for myeloma treatment followed by a transplant. For amyloid with cardiac involvement, the prognosis is generally poor in these patients. The next question is by Dr. Parak. Is the renal biopsy the only way to determine cause for renal derangement if patient has other factors like diabetes, obstructive uropathy? So again, patients with renal failure and M-band, those are very difficult to find out whether the patient has myeloma or not. If let's say you do the bone marrow and the bone marrow shows more than 60% of plasma cells, or the patient has lytic areas, then you are clear that you are dealing with myeloma. But many of these patients will have only anemia, which you are not sure whether this is because of myeloma or because of renal failure. Then, if these patients do not have lytic areas and the bone marrow plasma cells are less than 60%, then possibly you need to do a renal biopsy. The other reason for doing renal biopsy in those patients who present with renal failure are there are many causes of renal failure in myeloma, and these are immunoglobulin dependence, immunoglobulins independent parameters, and sometimes as a prognostication, you do the renal biopsy in many of these patients. Sometimes if it is cast nephropathy, we do plasmapheresis in these patients also to remove the light chains which are damaging the kidney. So it's a good question, but it again requires a separate 40 minutes or 45 minutes of talk about the kidney involvement in myeloma and doing the renal biopsy. But at MD level, you should know that you will make a diagnosis of myeloma only if you attribute the CRAF features because of the plasma cells and not otherwise. The next question is how routinely we should do workup for amyloidosis in multiple myeloma. So if clinical parameters are still important. So if you feel that the patient does not have any heart problem, patient does not have proteinuria, and the liver is not enlarged, the alkaline phosphatase is not high, so then most of the time you just do an FNC of abdominal fat pad, and if that is negative, you don't do further workup of amyloidosis. But let's say a myeloma patient has proteinuria, you do a serum protein electrophoresis that shows albuminuria instead of Benz-Jones proteinuria, then you know that possibly this patient has renal amyloidosis, or the patient has some cardiac dysfunction, You do an echocardiography, there is a restrictive cardiomyopathy, or many times you do an MRI of the heart to see whether it is related to amyloidosis or not. So depending upon the clinical situation, you would do the workup for amyloidosis. In some situations, the things are very clear, like proteinuria or restrictive cardiomyopathy. But in some patients, there is a subtle abnormality, and there you would treat most of these patients like myeloma only. The next question is, if the kappa lambda leg chance elevated both, but the ratio is normal, what does that mean? So, it's like when you do a serum protein electrophoresis, there is a hypergammaglobulinemia, which is polyclonal. So similarly, if both kappa and lambda chains are elevated, that means it is polyclonal. That happens in many times in autoimmune disorders, or many times, these are excreted through kidneys. So even patients with renal failure, both chains can be elevation with normal ratio. So the normal ratio varies from 0.65 to 1.26, but in renal failure patient, this comes down to, I think, 0.26 to 3 point something. But again, you have to see the patient as a whole. You just don't look at only at the kappa lambda light chains. You have to see the patient as a whole and then decide whether this patient has organ dysfunction because of the monoclonal kappa or lambda chains, or because of the monoclonal M-band, causing dysfunction, organ dysfunction in these patients. I hope I have answered most of the questions, but if, let's say, there is still you require a clarification on any of the questions, please type it again so that I can, uh, discuss more about that point. It's a complex field, so I can go on actually, but at MD level, we just want, you should know the CRAB criteria, myeloma defining events, the little bit about the medicine. You don't, need to know the regimens, but you just need to know the medicines and possibly their mechanism of action and their use in other circumstances. Like daratumumab is used even in autoimmune hemolytic anemia only. Bortezomib is used in kidney transplant, post-kidney transplant rejection also. Bortezomib is also used in autoimmune hemolytic anemia also. So cyclophosphamide, have many uses. So those are the things which are expected from at the MD level. I think I don't see any more questions. So you are again most welcome to. Okay, no, Madhav has. I'm sorry, I did not get how to differentiate between AL amyloidosis versus myeloma in case of M-band positivity with no myeloma defining events. Okay, so so there are more no. So whenever there is an M-band and you have done the bone marrow, you have looked at the calcium, you have looked at the anemia part, there is nothing there, and you do a bone marrow, there are less than 10% plasma cells. So you will say possibly this patient has Amgas. But you also have to say whether this patient has amyloidosis or not. And if there is an amyloidosis, obviously it will cause some organ dysfunction. So AL amyloidosis will cause either renal dysfunction, that means either 24-hour, and most of the time there is a proteinuria, and you do if there is a proteinuria, you do a 24-hour urine protein and it shows albuminuria. That means there is a likely possibility, and that you would confirm by doing a kidney biopsy. So on kidney biopsy, if there is a amyloidosis, then you will say this patient has AL amyloidosis. There is an M-band positivity, which you would do by immunofixation. We'll see whether it is lambda, IgG lambda, or what. Most of the time it is lambda. Let's say you have a large liver and high alkaline phosphatase, which you are unable to explain by any other illness, and you have an M-band positivity. You do a liver biopsy, you will find that there may be an amyloidosis. Or the third common presentation is you have a restrictive cardiomyopathy. You have an M-band. And in restrictive cardiomyopathy, you do an endomyocardial biopsy and you will find that there is a amyloid deposits in the endomyocardial biopsy. The other things which you see in patients with amyloidosis is sometimes skin changes, the large tongue, uh, which you can on clinical examination you can find. So again, repeating the things, the patient can present with amyloidosis-like features, and they may have pure amyloidosis, or the patients can present with myeloma features, and on investigation they may have amyloidosis along with myeloma, or the patients have both the features. Patients have amyloid also, and patients have myeloma also. So three conditions. I hope that clarifies some of the things. Otherwise, you can meet me personally. We can discuss more about this. All right. Okay, then thank you so much for attending this meeting. And as I said before, if you still have questions, you are most welcome to ask me anytime. Thank you so much.